you all to our academic extravaganza Tuesday tea time with Dr. Kawita Bapat ma'am. Today, this is our 8th session, and thank you for taking the time to join us today. As the topic is deep in thrombosis, and I would like to take this opportunity to introduce our eminent guest expert, Dr. Rosa Olyai ma'am and Dr. Kawita Singh ma'am from Jabalpur. Dr. Rosa ma'am is the director of Olyai Hospital Research Center, Gwalior. She's having an affiliation, board of member committee, Family Planning Association of India from 2021 to 23, chairperson SBC Madhya Pradesh from 2021 to 22, representative board of this is HUQUQ South Asia from year 2021 to 22, fellow and member of board of governing council Indian College of Obs-Gynae since 2018 to 21. She was vice president Foxy in year 2014, chairperson of adolescent health committee Foxy 2012, FIGO representative world session at the FIGO World Congress Rome in the year 2012 during the special session on preconceptional care, WHO consultant expert panel meeting for making global guidance on adolescent sexual reproductive health, Geneva, during year 2010 to 2011. She got many awards and national awards and publications. The prestigious award Dr. D.C. Datta on Foxy Best Publication Year 2011, book title Recent Advancement in Adolescent Health, award the prestigious Mehro Dhara Hansoti Prize, Foxy Best Committee Chairperson Activity Award in the year 2010 to 11, and over 1,000, sorry, excuse me, just over 1,000 peer review publication in index journal, CME publication and textbook, author of the 4 books and co-author of 8 books in obstetric and gynecology.
Before that, I'll just add one thing, that the Rosa is the first Foxian from Madhya Pradesh to become the vice president. So it's a really important and a prestigious for all Madhya Pradeshians. And same thing, she was the committee chair for the adolescent gynae. That is also the first person from the Madhya Pradesh to become a committee chair of the subject. Apart from this, a very highly accomplished girl. A girl means our friend, and the important point is very sweet from in and out, and the way she looks, the way she works. So over to you, Rosa, and over to you, Richa.
Thank you, Dr. Kawita, for the lovely words that you say. I think it reflects the good inside you, that you see the best in everyone. Thank you.
I would like to invite Dr. Kawita Singh ma'am from Jabalpur. She's professor and head of obstetric and gynecology, NSCB Medical College, Jabalpur, WHO master trainer on colposcopy and gynec oncosurgeon, organizing chairperson of AMPOG in 2013, AOGIN on 2013, Foxy Zonal Conference Yoga 2022, past president of Jabalpur Obs-Gynae Society, MTA and Rotary Club of Jabalpur State. More than 15 state and national award, more than 45 index publication, textbook chapters, international scientific monogram colposcopy, and PhD guide in gynec oncology. She is a passionate teacher for more than 23 years.
Just few things which I like to add, that the person with the maximum intelligence one can have, highly accomplished girl. And the important thing is, she is going to be the president of All Madhya Pradesh Association very soon. At present, she is a vice president and she is going to take over as early as possible. And another important, she has done a great conference at Jabalpur. Just we have seen her academic as well as administrative abilities soon in the month of October this year. October, Kawita? Yeah. So all congratulations, and over to you, Richa, and we'll make it fast.
Thank you, ma'am, for joining with us. I would like to hand over the session to Dr. Rosa, ma'am, now.
Rosa, unmute yourself.
This is the habit, you know. Well, at the outset, let me congratulate Dr. Kawita Bapat for organizing it so systematically and selecting such good faculty throughout. I've been observing the good sessions that you've been having. The best thing is that it's focused, to the point, lecturers to the good topic, and we discuss with the take-home messages.
Thank you so much.
on
I'll
my-
start it.
Yeah, on my personal note, of course, Dr. Kawita has been the just past president of Oxy. But many of us, many of the young people who have specially joined us here should also know about her postgraduate days. Well, I have witnessed in the hostel with her. I was living with her. And she has not changed at all. Her looks are the same. I don't know how you maintain that, Dr. Kawita. And, we used to always have issues in the hostel where there's no water, food is not good. We knew there's only one leader who would take us. We would go like to her and tell her, and she would make sure that things are done correctly. And I think the leadership quality that you have with the joyful attitude that you had during that time has remained with you. And that's how you're able to put together a good team on such Zoom meetings and regular CMEs. I know you've been traveling in and out, for your upcoming presidential election. You're the very first candidate from Madhya Pradesh who has got the guts to go forward.
Thank you so much. Thank you so much. We will, without wasting time, Rosa, our agenda is very simple, only 20 minutes.
No. Okay, so this is what I just wanted to say, and wish you all the best for
Thank you so much. Because I just want it should be really the learning platform.
It's
And
so nice to
experts
hear,
like you and Rosa, just you and Kawita should add something, good points, which everybody can learn from the deep vein thrombosis to this topic.
Certainly. Over to you, please. Over to
Thank you so much. Thank you so much. And I'm happy that I have called both of you very close to me. So again, this slide is not so important. I'm from Indore. So the case one, it's a 20 years post-dated pregnancy, 39 plus 4 weeks of gestation, according to first UCG scan. Admitted maternity ward for the planned induction of labor. Clinical settings, what interpreted a possible herniated disc with inflammation on the left sciatic nerve. She was medicated with analgesics, anti-inflammatory agents, fatigue worsened, shortness of birth, and successively less on exertion. 9th day, she suffered a brief loss of consciousness at home and oppressive chest pain, admitted under joint care of OBGYN emergency medicine. On physical examination, agitated, hypotensive, BP was low. This is a tachycardia, hypoxic, tachypneic, no signs of deep vein thrombosis were observed. Uterus 30 weeks, relaxed, fetal heart present with Doppler, fetus in a transverse position, and a good vital signs fetus. And the cardiotocos ECG is reactive with good variability and no uterine contractions. Again, these were the laboratory tests: hemoglobin 12, platelet 170, D-dimer 2962. Troponin was done because the reference value 0.43. Arterial blood gas analysis was being done and showed the respiratory alkalosis. So ECG showed a sinus tachycardia, right ventricular overload, and echocardiography. Ultrasound scan for the fetal brain showed a concordant fetal growth. Adequate amniotic fluid. Doppler's ultrasound, the lower limbs excluded a DVT. So according to the Wells score, the patient's clinical probability of acute pulmonary thromboembolism, that's a PTE, was intermediate, and she was medicated with a subcutaneous enoxaparin, and it is decided to perform thoracic computed TCT with administration of intravenous contrast and pulmonary arterial phase, and CT angiography confirmed the acute bilateral pulmonary thromboembolism. Another second case, 33-year-old, developed deep vein thrombosis left leg, reported a family history. Her mother had an episode of superficial thrombophlebitis. Brother had experienced DVT during 12-hour flight. Do you consider a DVT to be acquired, or it is likely to be associated with a congenital thrombosis risk factors? So what is deep vein thrombosis? Venous thrombotic events, that is we call this VTE, they are basically include two things. Number one is a deep vein thrombosis, and number two is a pulmonary embolism. They complicate 0.5 to 2%, 2 per 1,000 pregnancies. Again, VTE, one of the leading cause of maternal mortality in the developed nations, and according to 10 to 20% of the pregnancy-related maternal deaths in United States. I'm not talking about our country, but it is definitely in other countries, it's a big number. DVT account for 75 to 80% of VTE during pregnancy, with pulmonary, the embolism comprising the remaining 20 to 25%. So make it a point, when we talk about deep vein thrombosis, we should be worried about two things. Number one is VT and other is PE. So this is the simple thing, how thrombus goes up and how it works. Now it's suggesting to DVT include, there is a pain, there is a swelling, or there is a redness in the calf or the thigh when we talk about the deep vein thrombosis. Physical findings include objective evidence of calf swelling. A difference of calf circumference is more than 2 centimeters. Very, very important point. There is a localized redness, calf tenderness, or with or without palpable thrombotic cord. We can feel a cord over there. Then deep vein thrombosis, they have the Homan sign. It refers the pain in the calf in response to active dorsiflexion of the foot. So Homan sign is a very simple sign that can be elicited and found in. Pain in the calf is regarded as a positive Homan signs, and it's taken to be suggestive of acute DVT. However, the positive Homan sign is only around 30 to 40% sensitive, and a negative Homan sign does not exclude the diagnosis. So Homan sign has got the role, but we can say it is not the everything. Then sometimes there is an isolated iliac vein thrombosis, may present with abdominal pain, back pain, and a such swelling on the entire limb. During our courses of last 30 years, I have seen many cases of deep vein thrombosis, and especially postpartum we have seen. We have seen the antepartum also, and patient come with a cord sign. We have seen the Homan sign, sometimes abdominal pain, back pain, and a swelling of the entire limb is been seen. Again, there is a personal history of the VTE is the single most important risk factor is. What is the risk factor we can talk about in the VTE during pregnancy? Is the risk of recurrent VTE during the pregnancy. It increases 3 to 4-fold, 15 to 25% of the cases of VTE in a pregnancy in a recurrent event. So for example, if the patient is having VTE in a previous pregnancy, there are chances of having again 3 to 4 mortal chances are again. Now, this is the second most important individual risk. VTE pregnancy is the presence of inherited thrombophilia, such as factor 5, that's a Leiden mutation. Prothrombin gene mutation is there. There can be protein S, protein C, or antithrombin deficiency, or an acquired thrombophilia, just as we can say antiphospholipid antibody syndrome, which is present in a 20 to 50% of the women who experience VTE during pregnancy and puerperia. So make it a point, second important risk is the factor risk, prothrombin gene mutation, and acquired thrombophilia, or we can say antiphospholipid anti-syndrome. Other risk factors for the VTE include advanced maternal age, race, heart disease, sickle cell disease, diabetes, lupus, hypertension, hemoglobinopathy, smoking, multiple pregnancy, obesity, and a prolonged immobility, especially in the bed rest being offered to her during, and the weight is more, if she is hypertensive, some hemoglobinopathies, if she is having a multiple pregnancy or the advanced maternal age, they can. And trauma due to its hypercoagulable state and the cesarean delivery, especially the intrapartum emergency cesarean section. So the heavyweight female lying in the bed during the cesarean section, no movement or a trauma, or we can say if she is in a hypercoagulable state, can lead to the deep vein thrombosis. Then the VT is a 4-fold more common in pregnancy than a non-pregnant women. 2/3 of the DVT occur in antepartum, with this event disturbed throughout all 3 trimesters. So you cannot say it is more into the last trimester or the second trimester or the first trimester. It can be on all throughout trimesters. Again, in pregnancy should be treated to prevent propagation of thrombus and PE. Why we are worried about the deep vein thrombosis? There are chances that this thrombus can propagate and go into the lung and cause the pulmonary embolism. If untreated, 25% of the patient with DVT will have pulmonary embolism as compared to the 5% treated patient. So you make it a point, you are going to treat the patient of the DVT, still 5% can have a chance of pulmonary embolism. And if they are kept untreated, the chances is 25%. So out of 100 females, 25 will have the pulmonary embolism. Now, admission is generally warranted for the initiation of the treatment in the pregnancy. If we are able to diagnose the DVT, then when to start the initiation of the treatment? and what has to be done. Therapeutic subcutaneous low molecular weight heparin, this is a new, is now the treatment of choice in a DVT of the pregnancy. So low molecular weight heparin is the answer, and how it has to be given, why it's better than unfractionated heparin, why, when to choose it, how much to be given, it's very important. The advantage of low molecular weight heparin over unfractionized heparin include it, number one, it reduces the risk of bleeding. Number two, it's a predictable pharmacokinetics, allowing weight-based dosing without the need of monitoring. So very, very important. When we give the low molecular weight heparin, we can give it with the weight-based things, and we can predict it's a monitoring is not so different, but it also reduces the risk of heparin-induced thrombocytopenia, heparin-induced osteoporotic fractures. These are important. So low molecular weight heparin has got a unfractionized more importance over the unfractionized heparin. A twice daily weight adjusted dosing regime should be used, such as enoxaparin, 1 milligram per kg of the body weight, subcutaneous, 12 hourly. So this is the dose, and we should be given. Low molecular weight does not significantly alter the PTT. So it's another, prothrombin time is not being changed, but serum anti-factor XA activity can be measured. So we should know that the anti-factor XA will tell us in the monitoring that our low molecular weight heparin is good or not. So anti-factor XA assay designed to measure plasma heparin levels to monitor anticoagulant therapy. Therapeutic anticoagulation is achieved when we find out the anti-X factor is 0.6 to 1. So that's another important point. But the routine monitoring of anti-X activity may not be justified because there are the large studies and using the clinical endpoints demonstrate the optimal therapeutic anti-XA, low molecular weight heparin range, and those that will increase the safety or the efficacy of therapy. But it's a really evidence-based thing that we should do the anti-XA activity and the anti-XA factor, we should do it and we should find it out. The lack of accuracy and the reliability of the measurement and the lack of correction with the risk of bleeding recurrence and the cost. Number one is the cost, reliability, but these are the academic things which we should talk about. Now, again, the management of the isolated calf vein thrombosis is controversial. If there is only one thing which we see on this, with no established guidelines, there are no established guidelines to treat the isolated calf vein thrombosis. Since most iliofemoral thrombosis originate from the calf vein thrombosis, full anticoagulation with low molecular weight is suggested for the symptomatic patients. Again, just to make everyone understand where the anticoagulant and the factors are inhibited. When we use the low molecular weight heparin, only factor 10 works. But when we use the unfractionized heparin, the factor 2A and XA both works. So low molecular weight cannot be used when this unfractionized heparin in patients with a renal dysfunction or the delivery or the surgery is necessary. So this unfractionized heparin has got the role. We have to give it initially IV followed by subcutaneous. An IV treatment should be initiated with the loading dose of 80 units per kg and followed by initial infusion of 18 units per kg, this thing. Serum PTT should be checked every 4 to 6 hours and infusion should be adjusted. Once a steady state has been achieved, PTT levels should be measured daily. After 5 to 10 days, IV heparin should be changed to subcutaneous injection, not intramuscular because the risk of hematoma as follows. Begin with 10,000 units subcutaneous 3 times a daily. Titrate the dosage upward depending on the result of the mid-internal PTT and aim for PTT should not go. It's between the time control 1.5 to 2.5. When subcutaneous this fractionous heparin is used during pregnancy, higher doses and 3 times daily dosing are usually required to maintain adequate anticoagulation. Now, we are other than what we can do when we are not able to use the heparin. There are fibrinolytic agents and surgical intervention. But associated with the high incidence of complications in a pregnancy, both the things are avoided. So we cannot use the fibrinolytic agents also, and we cannot do the surgical interventions also. Now we can use the vena cava filters. This is also new, and this is considered for the patient in whom the anticoagulation is contraindicated. An extensive venous thromboembolism within the 2 weeks before the delivery is needed. So this is the vena cava filter, and which is inserted into the vena cava to stop this thing. And this is the way how this thrombosis develop. Number one is stasis happens, then vascular damage happen, and hypercoagulable stage happen. Compression of the veins, gravid uterus, hormones, and immobilization. Vascular damage, compression at delivery or the pre-delivery. And what it happens? Hypercoagulable blood, increased factors, increased fibrinogen 5, 9, and 10. Less anticoagulant activity, protein S, less fibrinolytic activity, more this thing, and more thrombin generation and less clot, these things. This is the normal vein, and that is how the pulling of the blood. Now, the treatment of acute DVT should be continued throughout the pregnancy and at least 6 weeks postpartum, because the minimum total duration of therapy 3 months. Women receiving the therapeutic low molecular weight may be switched to the therapeutic unfractionized heparin in the last month of the pregnancy, or if the delivery appears imminent due to the shorter half-life of the unfractionized heparin. And although the benefit of this approach has not been validated for the clinical studies. Alternatively, therapeutic low molecular weight heparin can be discontinued 24 hours prior to the induction of the labor. So either you switched off to the unfractionized heparin or stop it 24 hours before the induction of the labor. And the purpose of the conversion of this fractionized heparinase is primarily to reduce the risk of epidural or spinal hematoma with the regional anesthesia, and pharmacokinetics of subcutaneous fractionized heparin and low molecular weight heparin are quite similar, which may limit the benefits to the approach. Again, American Society talk about we should use the neuraxial anesthesia. It's so very similar what we do in epidural anesthesia or a spinal anesthesia. It should be placed, and that is very good with the placement of local anesthetic. And guidelines support that the patient receiving doses of 5,000 units of heparin twice daily, but the safety in patient receiving the 10,000 units twice daily is unknown. And pregnant women with a higher risk of recurrence, they should be worried about switch to therapeutic IV unfractionized heparin, which is discontinued 4 to 6 hours prior to the expected time of delivery or the epidural insertion. Again, this is a very important that we have to stop getting both the heparin just before the 24 hours of the delivery, so that we can have less and less bleeding. Otherwise, can be restarted no sooner 4 to 6 hours after the vaginal delivery and 6 to 12 hours after the cesarean delivery. So make it a take-home message. Take-home message is very, very simple. Stop giving low molecular weight heparin or unfractionized heparin just 24 hours before the delivery, and we can start it just after 16 to 12 hours of the cesarean delivery and 4 to 6 hours after the vaginal delivery. Women who require more than 6 weeks of the postpartum therapeutic anticoagulation may be bridged to warfarin. Warfarin, heparin, low molecular weight heparin, all are competent with the breastfeeding. That's another important point. So just a subject, this is I am concluding by telling you the algorithm which I love to talk about always. Take a detailed history of the perform a physical examination. Be aware of pre-existing risk factors of DVT. Check CBC, TND, coagulation studies. Determine the clinical probability. We can divide into 3 conditions. Either it's a low clinical suspicion, intermediate clinical suspicion, and high clinical suspicion. If there is a low clinical suspicion, no empiric anticoagulation. Make it a point very, very clear. Check over extremities with ultrasound. Normal, no DVT, just give the routine care. But if there we find an abnormal thing into the extremities on ultrasound, the diagnosis of DVT is confirmed, we need a therapeutic anticoagulation. Intermediate clinical suspicion is an important thing because no empiric anticoagulation. Check lower extremity. Normal, repeat ultrasound 1 week. Normal, no DVT. Abnormal, diagnose DVT, therapeutic anticoagulation. But when we have the high clinical suspicion, start empiric coagulation, check lower extremity ultrasound, abnormal, again therapeutic one, and go up to the peripartum anticoagulation. If it comes normal, but there is still a high clinical suspicion, you should go for the MRI. If it's come normal, routine care. If it's abnormal, again the therapeutic anticoagulation, and this is another important point. So the anticoagulation is very, very important. When it is completely diagnosed, then only, otherwise, and there is a high clinical suspicion is there. So thank you so much for the patient listening and joining today.